Thank you. So the draft minutes of the last meeting have been circulated. Are colleagues happy with the minutes in terms of their accuracy? Yeah. In terms of apologies, I should say we've got an apology from Arpan, who is on compassionate leave because of a bereavement in his family. The other apologies are connected with that incident. Otherwise, I expect Joe and Jill to join us. Jackie, did you want to record any apologies from your good selves?
Yes, we've got Michael Lloyd-Jones, Kelly Benton, Brace Griffiths, Linda Harper, Jill Williams, Stella Howard, Celia Hayward, Michael Boyle, Di Gill, and possibly Joy Baker, who's got some trouble with her broadband. Thank you, Chair.
Thank you. So we then move on to the minutes. As I say, are colleagues happy with the accuracy of the minutes?
Yeah.
Yes.
Yes.
Thank you. And then there were two actions. The first was for Teresa. Teresa, are you with us, and can you confirm that has been dealt with?
I'd recorded apologies, I think, from Teresa on your notes, Chair. So I'm expecting Ian Wilkie for the mental health item.
Okay. In the absence of anybody identified to the contrary, I'll assume that action has been dealt with.
Yes, Chair, both actions from the minutes went on to our wider health board action log, and so went back to board during 2020 and were closed down.
Okay, all right, thanks, Kate. Thanks for your guiding hand. Okay, thank you. So, Jackie, as I say, I won't come on to Joe's item because she's not with us. So if you're happy, we'll go to the COVID-19 and vaccination program first with Chris.
That's fine, Mark. So I believe Chris is going to talk to us on the COVID-19 and vaccination program. And I think you have got a presentation to deliver, Chris.
Thank you, Jackie. Yes, I have. Just bear with me for one moment whilst I just get that loaded. I'm hoping now that you can see that presentation.
Yes.
Fantastic. Thank you. Okay. So I'll take us through the slides, and then hopefully they'll lead into the necessary questions. So starting off in terms of coronavirus, it's worth reflecting, I think, that we have now been in a pandemic state in the UK for just over a year. I think we've all been on our individual journeys, but the collective journey has been a significant one. We've been through 3 waves in the UK of increased coronavirus activity within our communities, and that has been the case in North Wales too. In the last month or so, the levels of coronavirus transmission that we saw in December and January have started to come down nicely after what was the 3rd wave. If I was to show you that 3rd wave pictorially, this chart here shows the time period from December through to now. It is split down for each of our local authority areas. You'll see Denbighshire, Flintshire and Wrexham, and the very big spikes that occurred in those communities and compared to where they've come down to now, which is much lower, and levels at the moment that we haven't seen for many months. The same is to some degree mirrored in those local authority areas further west, although they're much flatter and slightly more prolonged, so flatter and longer. But in all of those areas now, we're seeing levels which are much lower than we have within our communities, which has got to be a good thing. In terms of our hospital inpatient activity, as you would imagine, that more or less follows the community levels of activity. So in the east, we saw a rise, which is now coming down nicely. In the central area, again, we saw a rise, not quite as high, but now coming down. And in the west, we also saw a rise, which was later than the rise in the east, and also now starting to come down. In all three waves, we've seen that activity a little bit later in our hospital provision in the west, so I do expect that to continue to decrease. At the moment, we have 105 inpatients in our hospitals receiving care for COVID or having recently had COVID. For the first time last week, I reported to board that 2 of our critical care units no longer had any patients with COVID in them, and that was a huge step forward for us. I'm going to move on now to the TTP programme. TTP is Test, Trace and Protect, and it's the public health programme which is underpinning the whole approach in Wales. It's an approach that we follow absolutely hand in hand with our partners, and is absolutely critical in terms of how we've got those levels down here in North Wales. In terms of our testing, we have excellent community testing provision in North Wales now, and that continues to be the case in almost all of our testing environments, of which there are multiple across North Wales. We have more testing capacity than people requiring tests, and so we're able to test people very quickly now as soon as they make contact with us. In addition, the test results come back comparatively quickly now compared to in those first and second waves where testing capacity was a little bit more of a challenge. And that makes it much easier now for us to not only ensure that we're picking up activity within communities really quickly, but it helps massively in terms of how we then trace people and ensure that onward transmission of coronavirus is limited. And I'll come back to that in a moment. As part of our testing programme, we have, along with other areas of Wales, rolled out an asymptomatic testing programme in the course of the last week or two. What this means now is that if you are an individual who cannot work from home, then if you request, then we will provide you with home tests, which you undertake twice a week, that you can, as the name suggests, undertake them from home. They give you a result within about half an hour or so. And if those results are positive, then you contact us, and then we would then arrange a laboratory test just to confirm that result, and then work through any contacts that need to be traced. At the moment, those test kits can be picked up each morning from 3 of our testing sites in North Wales. We're looking at expanding that as soon as we possibly can. The details for this are all on our website, so that when we have been able to expand collection points, we can keep people up to date. So that's a positive step forward for us here in North Wales. I referred to the trace and the contact tracing in Wales. We do backwards tracing as well as forwards tracing. What that means is forwards tracing is where you try to contact anybody that an individual has come into contact with after being diagnosed, after developing symptoms for COVID. Backwards tracing takes it a bit further, and that takes us to a place where we look to try and find the person that person caught their COVID from, and then trace back from that individual. It takes more time, it takes more people to do that, but all of the evolving evidence across the world demonstrates that taking a backward and a forward approach results in even better contact tracing. And we now have the capacity in North Wales, and have had for a little while now, to be able to do both forms of tracing. So that is an important point to share with you. The vaccination programme is an area that I next wanted to cover. The vaccinations, we have now given just over 500,000 COVID doses of vaccination here in North Wales. That's a phenomenal effort that has been successfully delivered by support from our partners, by provisioning how our own staff can provide that service, and with our partners, not least our GP and community pharmacy partners. Here in North Wales, we're using 2 vaccines. There are 3 vaccines that have been licensed in the UK, Pfizer, AstraZeneca and Moderna. There are very small numbers of Moderna vaccine currently available, and for that reason, we're using those in just 2 health boards here in Wales. But the distribution of vaccine has been done in an equitable fashion. So we have more Pfizer vaccine than they have to compensate for the Moderna vaccine that those 2 health boards have, and to ensure that we have a viable alternative to the AstraZeneca vaccine, for reasons that I will come on to in a moment. So we're using Pfizer and AstraZeneca vaccine. Within the 527,000 doses so far given, around 100,000 or just over 100,000 of those are second doses. You'll see from the graphic, it's not far off 50-50 in terms of Pfizer and AstraZeneca vaccine in terms of our use so far. We've got a little bit more of our Pfizer having gone for second doses. That's only because the Pfizer vaccine was available a little bit sooner than the AstraZeneca vaccine. And that means that more people have got to their time schedule for their second dose for Pfizer than has been the case for AstraZeneca. So those numbers will catch up as we get closer to the 12-week or so period, and have made sure that there's sufficient vaccine held back for those second doses to be undertaken when they are due. This chart shows the 10 categories that the Joint Committee for Vaccine and MHRA and the UK chief medical officers have agreed as being the right cohorts for vaccinating and the right order for vaccinating individuals. And you'll see, if we look at first doses and second doses, that as we move down those categories in risk order, almost all of those groups have now received their first dose, which is the dose that gives the greatest protection for individuals. The numbers reduce slightly as we go down, which reflects the fact that we've only recently been vaccinating the lower cohorts. Cohort 10 at the bottom is the cohort that we've just this last week or so moved into, and we're currently at 31% in that cohort. Alongside and in parallel to this, we're catching individuals for their second doses when they become due. At the moment, it's really only the top 3 cohorts that have been due for their second doses, which shows that their levels are pretty similar to their first doses, showing that the majority of people have now received a full course there. In the coming few weeks, we'll see full courses follow through to those other cohorts a little lower, as I've just said. So really strong progress being made in terms of vaccinating, not just across Wales, but I specifically call out our vaccination in North Wales, and the fact that we are rapidly moving through our population. It is true to say it is an extremely challenging environment, a very complex programme for lots of different reasons, which we don't need to rehearse again. I'm sure people have seen much of this on the news. We are just about to launch 2 Zoom events for members of the public. I'm really pleased to be able to share this with you, because it reflects in part the enthusiasm with which our team has taken to sharing as much information as possible on vaccination with members of the public, but also how we can do that in partnership with other organisations here in North Wales. The first of those events is next week. There's an event the week after. Details are on our website in terms of how to join into those events. We'd welcome anybody who wishes to join, not just those people that haven't had their vaccine but have some questions or concerns, but actually also those people who have received the vaccine, who want to share their experiences of that. Everybody's welcome, and the purpose is really to improve people's knowledge and awareness of the programme. We are running a No One Left Behind programme here in North Wales. It's really important, and has been really important in the course of the last few months, to continually remind people that we think we know most individuals from their GP records, from their hospital records, but we don't know everybody, and sometimes people have moved, and sometimes contact details have changed. So that whilst we do try to contact everybody at their right cohorted time, if you haven't been contacted, please don't worry. It's not because we've taken against you, it's simply because of one of the many technical challenges within such a complex programme. And if you get in contact with us, we will put you back to where you ought to be in that programme and make sure you get vaccinated. In the last couple of weeks, it's been especially busy in terms of trying to get through on the 03000 number. As you would expect, cohort 10 is a very large cohort, and as we've opened that cohort up, there's been lots of inquiries from people who are predominantly working and need to change appointments, and all sorts of other questions relating to AstraZeneca vaccine in particular. So the call line has been particularly busy. It means that at times it's been hard to get through. So what we have put alongside is a web form so that people can just contact us through completing the web form. Absolutely recognise that not everybody is IT literate or has access to the internet. If you do have access, it's a really simple way of doing it, and it does then free up capacity for those people who need to speak to somebody. So it is there as an alternative to speaking to somebody. You can either ask for your appointment to be arranged or rearranged, or you can contact us to tell us that you haven't yet heard from us, but you think you should have done. And in both cases, we will then get in touch with you with a more appropriate appointment offer for you. I did just reference the AstraZeneca vaccine and some of the communications that we've been having with regards to this. I'm sure you're all aware of the recent changes to the guidelines for using the Oxford AstraZeneca vaccine, which are that if you have not received any doses of it yet and are under the age of 30, then you shouldn't receive the Oxford AstraZeneca vaccine unless there are particular reasons to do so, and should normally be offered an alternative. That means Pfizer or the Moderna vaccine. For us in North Wales, there's around 70,000 individuals who fall within this particular group. Now, it's important because when you work through the mathematics of how many vaccines are available in the UK and which are currently licensed and which are currently in production and available, and take into account that 70,000 individuals, it means that we have just about enough Pfizer and Moderna vaccine to be able to vaccinate the under 30s, the adults under 30, but not much surplus to that. And that means that at the moment we're in a position of making an offer to those under 30 of the Pfizer vaccine and those over 30 of the Oxford AstraZeneca vaccine. Now, both vaccines are being delivered to us on a weekly basis. And because we don't want to keep vaccines in the freezer or in the fridge rather than in people's arms any longer than is necessary, then what you will experience, and people have already experienced, is that there will be some people under the age of 30 who are receiving appointments, even though their neighbours who are between 30 and 50 have not yet received their appointment. This isn't because people have been overlooked. It isn't because we think it's right to offer to the entire group without any priority. It's because we're having to run an under 30 adult stream at the same time as a 30 to 50 adult stream, so that we can administer all vaccines as soon as we get them. It's a process that we will work through over the course of the next few weeks until we've vaccinated the entire adult population, and we remain on target to do that by July. We are committed to deliver our vaccines as close to individual communities as possible. You'll be aware that we've delivered a large amount of vaccine so far through mass vaccination centres on 3 or 4 sites in North Wales. We are looking actively to move that provision into local communities. It's not easy, particularly with the Pfizer vaccine, because of the handling requirements that we need to work with for that vaccine. But we have plans now for most communities to be able to deliver that vaccine close to those localities. Where possible, we're using our primary care providers, but not all of our primary care providers are currently in a position to be able to continue to vaccinate. There are lots of reasons for that. It's a very labour-intensive process, and some practices are probably better spending their time and effort now trying to catch up on some of the unplanned cancelled activity during the coronavirus pandemic rather than vaccinating. Where that's the case, we're looking to put in alternative provision. So lots and lots of work underway to maintain that local footprint, but that is exactly what we will do. And alongside that, quite a lot of work underway at the moment in terms of possible booster programmes for the autumn and winter. Those programmes are still being worked through by the experts in terms of what is right and what isn't, what we should be delivering, who to and when. So as soon as the science behind it has been agreed, then we'll be able to roll out those booster programs too. On that note, I'll stop presenting, but I'm very happy to pick up any questions.
Chris, before I open it up, a couple of things. First of all, we've invested a lot of time in briefing stakeholders as we've gone through the vaccination programme. So there have been regular sessions with the members of the Senate and MPs from each of the political parties, albeit that is largely on hold now because of PERDA. And Chris, did you just want to cover the query we've had this week as far as you can in terms of Flintshire? Flintshire appears to be falling behind in terms of the more recent groups, but you're you're examining that, I know. Can we just touch upon that?
It does. We publish our data on a daily basis and have done all the way through. I've always believed that to be the right thing to do from a transparency perspective, and so we've provided as much granular detail as possible. And one of the things that that has identified over the course of the last week or so is that local authority areas are getting through different cohorts of the population at slightly different times. There are lots of reasons for that, and we intervene on a daily basis to try and even that out. This week, what we have identified is that there is a lower uptake of vaccination in Flintshire for the 40 to 49 year populations. There are, as we've looked into this, a number of reasons for this. Some of it is in terms of GP capacity, but some of it is also in terms of mass vaccination capacity, and some of it is in terms of local community understanding and confidence in the vaccine. In addition, there's probably a group of individuals that we haven't yet captured who have had their vaccinations in England because they're working in health and social care environments in England. So when we capture those pieces of information, it does make the numbers more comparable to other local authority areas. And also when we factor in those people that have appointments booked in the next couple of weeks. All of that said, we're now going away to do a little bit more work in terms of what additional capacity we can put into place in Flintshire over the next week or two, just to catch up and make sure that the distribution across all of our communities is more or less hand in hand as we carry on through cohort 10.
Thanks, Chris. It's much appreciated. We appreciate how busy you are, especially during this vaccine. Chris is prepared to take questions from the floor. So if you have got a question for Chris, if you'd like to put your camera on and your microphone and ask your question, that would be appreciated.
No?
Sorry, I can't work this. Am I all right to speak, Jackie?
Yes, go ahead, Sean.
It's not a question, Chris. It's a compliment, really. I've just come back from my GP's practice, having had my second one 5 minutes before the meeting. I've never seen anything run so smooth, and I've never seen so much information given to us. And I'm not the only person that's saying that. So it's just a compliment to you and your team.
Excellent. Thanks for that, Sean.
No problem.
Thanks very much, Sean.
You're welcome.
Chris, it looks as though you've got off lightly today. I think everybody appreciates the work you're doing and the speed at which you're delivering the vaccine, and also the fairness in which the vaccine is being delivered across the 6 counties. I know there were teething troubles to start with, and we kept an eye on things. We know that when Jeff brought these to the attention of your department or whoever was looking after the vaccine, it was dealt with speed and efficiency, and we didn't encounter those problems again. So thanks very much for taking up our comments in that way, and keep up the good work. So thank you very much, Chris.
Thank you, Jackie.
Now, I think, Chris, I don't know if Joe's with us now. If you want to go to Joe's presentation, Mark?
She should be with us. Joe, are you still with us?
I am, yes, and happy to do my agenda item now. And if I do need to step out once I've finished, I'll leave a message on the sidebar. Thank you. So I would like to say thank you to CHC colleagues for their welcome on my return to North Wales. I've had the opportunity to meet with CHC officials and with Jackie in advance of presenting to the full CHC Council this week. So I would just like to say a very big thank you for the time you've already given me. And I'd like to acknowledge the important role that the CHC does play, given your responsibility for representing independently the interests of the patients and the public of North Wales in order to hold us to account in a journey of improvement, both in terms of how we plan and how we provide our care. And Jackie described the role of the CHC as a critical friend. That independence is very much in play, as I observe in the relationship between the CHC and Betsy Cadwallader, and we appreciate and welcome your critical friend relationship with us. I thought I might start just with some personal observations, being back into North Wales, about the organisation that I'm privileged to be a part of, serving the population of North Wales. I always like to describe myself as a public servant, because I think that's the best way of thinking about the role as chief executive of a healthcare provider, here to serve the population of North Wales. And I will talk a little about our emerging organisational priorities, but I would just like to speak for a few moments about my personal priorities coming into the job. As some of you will know, I'm a person who likes to put the patient at the heart of the work that we're doing. And speaking as a person whose family members have received the care and support of Betsy Cadwallader and its predecessor organisations across that, and also social care. And whilst my experience is only one person's experience, that experience is on my mind as I think about how we can consider our improvement journey. I feel very passionately that our staff, our clinicians, our co-colleagues are the key partners in service delivery and in the provision of perfect patient experiences, or as close as possible that we can get to. Because of course our aspiration, our staff's aspiration, is to provide services that we would be comfortable to receive ourselves or for our family members to receive. And where there are areas for improvement, and there always are those areas in healthcare, that we openly and transparently work on those areas for improvement for the benefit of the population of North Wales as a whole, in order to improve health and care outcomes. So I do think it is important as an organisation we seek to create an organisational culture which enables our clinicians to thrive, to grow, and to have the flexibility and freedom to deliver the best policy, the best possible healthcare that is consistently provided across the organisation as a whole, and is consistent with best quality care standards. I think it's important as an organisation that we develop our approach to engagement, to thinking through how we can talk about co-design, co-delivery, engagement and consultation about our services, both on a day-to-day basis and as we think about developing our clinical services plan in the context of living healthier, staying well, and the principles of a healthier Wales. It's important to me that we acknowledge that that healthcare starts at home, with family, with self-care, continues to be provided by primary and community care, into acute services, and into specialist and tertiary services. And from an individual patient, family or carer point of view, whilst the boundaries between those levels of care, all between health and social care, may seem important to organisations, to individuals they are less so. And it's important for Betsy and all of our partner organisations in each locality that we think about how we can deliver care that genuinely has the patient at the heart. Just thinking about our priorities for future years from an organisational point of view. We have, as Chris has spoken, had well over a year now of our COVID-19 response, and we anticipate we will need to continue to be in response mode with regard to COVID-19 for a little while yet, whether that's around testing or vaccination, or whether that's around the continuing provision of support for patients with long COVID, or in a more acute phase, or in a rehabilitation phase. We see that COVID-19 will continue to be a priority for us and our partners during the next period of time. In line with my own personal agenda, and something that the organisation has been committed to and is part of our Living Healthier, Staying Well ethos, is a population healthcare focus. And if COVID-19 has reminded us of anything, it has certainly reminded us of the fact that COVID-19 across internationally has had an impact on some of our more deprived communities and some of our different populations. And maintaining a focus on population and the prevention agenda remains one of our organisational priorities. And linked to that, as does a focus on primary and community care, to enable patients, people to receive the right care in the right place at the right time. I've already spoken about COVID-19 in the context of our COVID-19 response, and part of our response to COVID-19 also includes a consideration of the increased waiting times associated with inpatient diagnostic and outpatient care as a consequence of us needing to pause surgery at points in time over the last period of time, and to reflect the fact that in some circumstances, because of the requirements to use enhanced PPE, it is harder for us to treat quite so many patients through our theatres than has been the case. We have already started to implement and think about our planned care recovery. Indeed, that is a separate agenda item for discussion later on during this board to board. In parallel with improving our planned care pathways, we need to maintain our focus on ensuring that patients are able to access unscheduled or emergency or urgent care in a timely and appropriate manner. Whether that's whether that's urgent care from a primary care point of view, or indeed at one of the other ends of the care spectrum into our emergency departments within the agreed timeframes. And again, a priority which is referenced later on in terms of our board-to-board agenda, an ongoing priority for mental health services. Now, it's not to say, as I outline our key priorities going forward, that the only things as an organisation we will be focusing on are those areas that I have drawn out for particular attention. An organisation the size of Betsy Cadwallader operates, of course, across a vast range of services across a large geography. And of course, there will be other areas of service development and priorities that we will continue to focus upon as we move into this financial year and across the longer term. I'm very happy to take any questions or comments on either my personal priorities or the priorities I've outlined for our organisation. Thank you.
Jo, thank you very much for that presentation. I appreciate the job that you've got ahead of you. It isn't a small area of work, it's massive, and with the community hospitals, COVID and everything, it is going to be very difficult. You touched slightly on refer to treatment. I've got a question which you probably can't answer as yet, but I'm concerned about the number of people in our communities that haven't yet had that first referral visit, that have been to their GP and are sitting on the sidelines waiting and wondering how long it's going to be before they have their initial consultation. There must be an awful lot of people throughout North Wales that are feeling, when am I going to get that telephone, or when am I going to get that email? Have you any idea on how we're going to overcome some of these fears for the community?
Thank you. And Jackie, you're right to acknowledge not only the patients who are waiting on our outpatient day case or inpatient waiting lists, but also those patients who are being managed by their primary care clinician, and then a group of patients who I think we do all absolutely worry about, those patients who are managing their conditions and haven't yet gone to their GP. We are already starting to restart some of our planned care services, and are already operating waiting list initiatives on some of our sites in the week at the weekends, in order for us to be able to start to work down the list of patients that we do have. A lot of our communications through social media and more generally into primary care is to give the message that please don't sit on your symptoms. If you are worried, if you do have a concern, please do see your general practitioner. And if those symptoms are significantly concerning, we will, in the normal way, make every endeavour to see those patients in strict clinical urgency. Unfortunately, that does mean some of the patients that we like to describe as routine patients, but I absolutely acknowledge there's nothing routine about waiting with a painful hip or knee for a replacement. But it does mean that some of those waiting times for some of those specialties will unfortunately be extended. Now, the good news is that in partnership with Welsh Government, we are working very hard to invest additional resources, new money, into putting additional capacity in, not just on the hospital sites with theatres, day case facilities, and extra imaging being brought in, but also into primary care to ensure that where possible, people are able to be managed in primary care too. Thank you.
Thanks, Jo. It is appreciated because, as I say, it is a concern. The other concern is the length of time that it's going to take you to get back on track. And we're also concerned about where money is fine from Welsh Government, and you need that money to provide additional services. But where are you going to get the resource to actually address the additional capacity that you'll need?
Thank you, Jackie. It is nice to have the additional resources in acknowledgement of the additional activity that we need to complete. And the answer to the finding the doctors, the nurses, and the other practitioners who together create the multidisciplinary team is variable depending on specialties. So, for example, we are looking at partnerships with providers who are willing to work with us to provide additional medical and nursing staff, along with additional physical capacity, to use our theatre space at the weekends and in the evenings when they're not routinely used by our own staff. So we are already working with teams of staff who support our own employed staff, so that they can have a break, and we can still offer those weekend surgeries for those patients. We always have had a history of working well in partnership in North Wales with our private sector colleagues, and we would anticipate some of those private sector arrangements by way of waiting list initiatives continuing, because we see that as a positive partnership in order to reduce waiting times. We're also looking at very innovative staffing models. So Health Education Improvement Wales have over a number of years been training physician assistants, and we have also a strong history of training clinical nurse consultants and utilising pharmacists in a range of enhanced roles, all of which under the supervision of registered clinicians make a really great additional contribution to our workforce across primary and secondary care. And I certainly think those innovative models of care will continue to be developed in Wales and will continue to be used. My final point is one of strategy, and that is we are hopeful that the development of a North Wales medical and medical sciences school, it will become a possibility, because we see that important development for North Wales as being a really great opportunity for us to look at the range of skills and to increase the research and innovation within North Wales, which in turn will help us attract the numbers of clinicians that we will need in order to deal with the volume of work associated with our COVID-19 backlog. Thank you.
Thanks very much, Jo. Much appreciated.
So is there anybody else who wants to ask a question? I can't see any hands, but now's the opportunity to do so.
Yeah, I've got Vicky. Vicky Harvey has had her hand up for a while, and also Adrian Thomas. So Vicky, if you'd like to come in now.
Thank you. Jo, thanks for the presentation, and I found the one last week very interesting. I have to say my family's had very good treatment, both from our local GP and from Ms. Bitty Gwyneth. Got no real complaints, but I do find sometimes communications could be a little better. Now, last July, my husband went to the GP and was referred to a specialist, or he was told he would be referred to a specialist. We've heard nothing since, so that's 10.5 months. Okay, I know things are tight. It may be another year before he's seen, but at the moment, we don't know whether actually did the referral happen. Perhaps if we rang up and inquired, we'd find he hadn't been referred, there'd been a mistake. Is it possible to have perhaps some sort of just a confirmatory letter or a text or call saying, "Dear Mr. Harvey, your GP referred you, we're very busy. We'll be in touch within the next 6 months, 12 months, 18 months, whatever it happens to be." You're muted, Jo.
There's always one, isn't there, Vicky? There is always one. Apologies. Vicky, if you let me have your husband's details outside of this call, I will follow up his individual case. But to your more general point, that is a really interesting suggestion. And if I may, I'd like to take that back and talk to our colleagues about the feasibility. More and more, we are using the phone to text communicate. And please let me go back and follow up your idea, which I think is a really helpful one. Thank you.
Adrian.
Thank you, Chair. I just wanted to add some detail, if I may, just around sort of what Jo had said around what we were doing, about what we were doing specifically around diagnostics. So just some examples there where we have contracts in place to insource additional capacity in endoscopy and in radiology, and we've got additional radiology, MRI and CT scanners on sites across North Wales. We've also done some insourcing for neurophysiology, and we'll do some more of that in the future. And cardiology are looking at their waiting times as well, and you know, helping each other out across North Wales. And just I suppose as a note, the number of patients waiting over 8 weeks came down by 1,800 between February and March. So I guess just a bit of a demonstration of how hard our teams are working to take things forwards. We introduced some things during COVID as well. So FIT testing, trying to reduce endoscopy, local anaesthetic template biopsy. So other things that we did or introduced during the pandemic, which are also helping, and service innovations around that. So just wanted to add something to that. I thought it might be useful.
Thanks, Adrian. So Jackie, before we move off this item, I've got some observations to make too. And they start with the fact that there are, in my view, reasons to be positive and to look to the future with some ambition. That starts with Joe's arrival, who was clearly appointed by me and others. And I have to say, and it's only 4 months in, but I find Joe to be impressive. And we share a sense of the priorities moving forward and how we should pursue them. The second thing is that the £82 million awarded by Welsh Government over the next 3 years was hard fought, but is a recognition of a growing confidence in the organisation to invest that money wisely, but also to give us some flexibility in terms of focusing more on service improvement and transformation than trying to save money, albeit the £82 million awarded is clearly not a panacea because it has not cured all of our financial challenges, but it is a sign of growing confidence in the organisation. Of course, that's reflected in the de-escalation from special measures to TI, targeted intervention. Now, there are different views, no doubt, in this room or in this call about whether that was truly merited, and I have some views on that myself, but nevertheless, that has occurred. It has enabled us in the conversation with Welsh Government to be clear about what their expectations are in terms of the new framework, which was not always present in the past. And some of the other positive dialogue that's taking place and some signs of support and ambition. Joe's already touched upon the medical school. Joe and her team and Yuan at the university and his team are working very closely on establishing the case for that medical school, and colleagues in the call will all know, I'm sure, that each of the party manifestos now reflects the fact that they believe a medical school will be coming to North Wales. And then finally, the scale of some of the plans that are now emerging, either in terms of the diagnostic and treatment centres or some other key initiatives. And Joe and I are absolutely convinced, I think, that what we've got to do is to put more dilemmas at the door of Welsh Government in terms of how we want to improve services up here in the north in favour of our communities and patients. And, you know, there will come a time, won't there, whereby we, of course, will be seeking to engage you in understanding what some of those changes are going to be, to see you discharge your statutory responsibilities, but hopefully assist us in where the case is justified, helping us to make that case to stakeholders, to communities, to patients, but also, as importantly, to Welsh Government. So I do think, and notwithstanding all the challenges that we face at the moment, including COVID, there is reason to look forward with some positivity for the reasons I've described. And some will know I wouldn't say that if I didn't think there was merit in what I was saying and the scope to be positive.
Thanks, Mark. Perhaps we finish this agenda item a little bit too quickly because there does appear to be another hand that's been up for some time. So if Joe's prepared to take a question again, thanks, Joe. It's Shan Ramasir.
Thank you. Joe, I know you've got a big task in front of you, but will you be looking at existing services and how we can improve on those? Stroke is the bugbear for me. I think we've come from having a specialist stroke unit based at St Asaph, a specialist stroke outreach team, which was run by the medics there, to being in an environment with which was conducive with rehabilitation, now to be in the main hospital in one ward. And I'm wondering whether that's going to be on your longer term agenda to look at how we can get back to a place of excellence, which was the stroke unit, in the future.
Thank you, Sian. Stroke services is just one example of a priority that we will be pursuing right now, and we have invested quite significantly in developing in a stroke business case, which is due to go live, if you like, with a model of care which it definitely complements and adds to the acute hospital-based stroke provision. So yes, the effort is around existing services as well as around urgent and planned care, and we are, as an organisation, increasing our investment in stroke services during the current financial year. Thank you.
Thank you.
Thanks very much, Jo, for taking the time out. Thank you so much. I think our next agenda item is on planned care, and I believe Jill's with us now and is going to give us a presentation.
I am, and thank you, Jackie. And some of the points that have been made in Jo's, I think Chris is going to share for me because I've got a few problems with my technology. Is that right, Chris? Thank you. The point I was going to make is that some of the points that Jo has made, I will reinforce and would really welcome some feedback on this. Planned care really is a challenge. It was a challenge for us before COVID. It's a significant challenge for us now, and you'll have heard that across all health services. But it is something that we've been working on throughout the COVID last 12 months. And I will thank colleagues on this call who have supported us in some of the work that we've been doing to maintain our essential services, which has supported both our staff, but also our patients and public have been flexible in attending sites up and down North Wales to ensure that we've maintained those essential services. And actually that is something we have learned from COVID, and we are keen that we have equity across the whole of North Wales for some of these services that people are accessing. So we're talking about the single cancer pathway, and the work that has been done has been quite significant across North Wales, but again, it does remain a challenge. And one of the concerns that we do have is that many of the people who are diagnosed with cancer will not come through a formalised, what we would term urgent cancer referral. They will come through presentations in other ways. So we are really cognizant of the fact that our single cancer pathway, a big part of this is ensuring the public and indeed our primary care colleagues are working alongside us so that we can ensure that people get access at the earliest moment. And you'll have heard Adrian's point earlier about the investment that the Health Board has made to ensure that we are maintaining provision of endoscopy, CT and diagnostics to support that. I also want to touch on some of the different ways of working, and as I've alluded to earlier, we have seen our staff collaborate and corroborate in a very different way over the last 12 months, and that has been fantastic. It's something we want to build upon. It's allowed us to develop a number of cross-system pathways from primary care into secondary care and support the Home First agenda when we're discharging. But that is something we need to build upon. And I've alluded to as well that as we get into some of those subspecialties, some of those different waiting lists, the principles of our staff being far more flexible has been critical and will remain is remaining very much in our sites. You'll also have seen that we've done a lot of virtual platform working. That is not just about clinics for our accessing our patients and publics via virtual clinics, but some of the things that we do want to build upon is ensuring that specialist advice is available to primary care practitioners and other practitioners that may deflect an emergency attendance at our ED or an unnecessary outpatient appointment. So we want to build on those different ways of working. We'll come on in the slides to the restart of routine activity, and can I just say, in again, support from yourselves, we have been able to ensure that prioritised care has taken place, and we've worked that on the P1 to P4 principles that you've seen in the Welsh Government guidance. That has been clinically driven to ensure that we are seeing those most in need of the services first. That has meant a big inequity and a growing of our waiting lists. But what we have seen is Wrexham Myler has recommenced nearly all of its activity, and orthopaedics is scheduled to come in place on May. What I will say, and I think Jo alluded to in her presentation, is we're not seeing the same level of, dare I say, efficiency when we're undertaking those lists, because there is the increase in PPE. We're obviously ensuring that those patients are both vaccinated, staff are vaccinated, tested. So all of that has meant that the efficiency, both in our diagnostics and in our elective care, has not been as we would have wished. And even now, when we're returning it to a more normalised platform. Glen Clwyd, as you will see, is commencing elective activity in April, with orthopaedics in May. Spitty Gwynedd, again, is beginning to commence that elective activity. But we have had outbreaks across our sites. I think it would be reasonable to say in any third wave, I'm not going to say that we're never going to have another outbreak. I am sure we will. It's our response to those outbreaks that is important, but it has impacted our ability to undertake surgery. Chris, you're doing a great job as the slide person. Thank you very much. So want to focus on some of those that are most challenging, and eye care is one of those that is most challenging. We're working with Welsh Government what we can do for a centralised cataract centre, but conscious whatever we do there is going to take some time. So in the background, we are scoping the use of mobile cataract theatres. You will have, I'm sure, heard of those being utilised elsewhere in the UK, and the principle is that will enable us to do things quickly. Is also responsive to some of the geographical challenges that we see across North Wales. We are also conscious that there is inequity in the waiting lists in West, Centre and East. So we are really keen that we equalise that wherever possible, so that we are managing that as a single list, so that the people most in need of that or have been waiting the longest are seen first. So moving on to cancer, I alluded to at the beginning, and Jo, I heard you talk about the patients being part of the health conversation and the responsibilities that we have as individuals. So training our staff, working with our staff to help educate the population to spot the signs and not be afraid to come forward. The earlier we can catch this, the better the outcomes. So we are maximising early contact with the healthcare professional. And again, as Adrian alluded to, really trying to prioritise those diagnostics closer to the patient. So we're looking at community access to diagnostics, and you'll know, because I know I've spoken to some of your members about the principles of building on a diagnostic treatment centre model across North Wales to separate planned care from unscheduled care, learn the lessons and COVID, and protect that planned care moving forward. And we have had conversations and continue to have conversations with Welsh Government about progressing that, but clearly that is going to take some time. In the meantime, we are exploring and putting additional theatres on our sites, portable temporary theatres on our sites and temporary wards on our sites, in order to separate and ensure that we've got as green a pathway as we can for our planned care, and really focusing on a once for North Wales approach to reduce that variation. I think this slide is self-explanatory and does give you a sense of the size of the problem, that the challenge, I would say, that the organisation is facing. And I pick up the point that was made earlier about people acknowledging that this is a challenge for not just Betsy, but the health system across the whole of the world, I would suggest right now, is how we manage that planned care waiting list, but actually ensure that we are communicating with our public, so they know exactly what is going on. And I'm pleased to let people know, and I believe it is being communicated today, that we have opened a part of our website around frequently asked questions, and we are aiming to reach out to everyone on that waiting list, not the follow-up waiting list, but the waiting list over the next weeks, to ensure that we've got the details and that those details are appropriate. And in some cases, whether people still want that procedure, some of them may have had it, some of them may have decided that is not a procedure they want. Now they're in a different place. So it gives you a sense of the numbers, it gives you the sense of the challenge. And on the next slide, it will tell you that for that does mean that in order to get a recovery, recalling that before COVID, we were still looking at an 18-month recovery, 18 months to 2 years. This has now been pushed back to 4 to 5 years, particularly for specialties such as orthopaedics. So there is a lot of work being undertaken within orthopaedics to see how we can deliver services differently. I have talked about the Diagnostic Treatment Centre, but there are also prehabilitation pathways going in place, and this isn't just for orthopaedics, it is around some of the cancer pathways as well, so that we can keep people as fit and healthy and as ready for their procedures, so they can be as ready for their procedures as is possible. And that will, of course, have the double benefit of ensuring that people can recover quicker from those procedures as well. But when we look at orthopaedics, particularly some of the public health interventions we can make and support the public with, that could mean that procedure is no longer required. So we're really keen on developing and implementing a prehabilitation pathway, as we're calling it. The urology robot was delayed due to some of the procurement around Welsh Government, but we are comfortable that will be deployed in the summer. And I know, Joe, as the CEO, you are heavily engaged in those conversations with partner CEOs to get updates on that particular initiative. So we are looking at that being deployed in the summer. All of our sites are working on recovery plans, and Welsh Government have given us access to some additional funding. There may well be more, but they have given us access to bid against additional funding to fast track some of the work that we want to do. And those bids are being developed, and our first submission of those plans and principles I think, Joe, you are aiming to sign off this week so that we can ensure that we can progress those as quickly as possible. But again, apologies, Joe, because I missed some of your presentation, but we have used some of the funding that we were given by Welsh Government to ensure that some of those high-risk specialties, high-risk areas are given early support to progress. So in terms of our next steps, we will continue with the risk stratification of weights rather than just time weighting. I think time weighting now is not the most positive indicator that we can use, although it is one of the indicators we will use as part of that risk stratification. Reiterate the requirement to work in partnership with other stakeholders around the education and promotion to avoid surgical interventions where possible. Expand virtual healthcare, acknowledging though that there are those where digital options are not appropriate, and ensure that we are focusing on the right individuals for that virtual healthcare and virtual consultation. And I will say that means access for our own practitioners to get that virtual advice. So we've been using something called Consultant Connect during COVID, where primary care and other practitioners have had access to consultant experts. That has been well received, and it's something that we want to continue. I've alluded to the additional modular theatre that we're bringing on site in the coming months. It's likely that that will be towards the end of the summer months, because we have to make the sites ready for that in terms of not only space, but ensuring that we have the appropriate services built in. Continuing and extending that once for North Wales approach for all patients, so that we don't have people waiting different lengths of time across North Wales, acknowledging that some people may prefer to wait slightly longer and be at their most local site. So we recognise there's a balance there. We are working to maximise our current capacity, given the backdrop that Joe has described and I've described, in terms of perhaps the efficiencies that we were driving previously is not the option we've got available to us now, but we are looking at best practice across the UK to see how we can improve our current efficiency and work with our clinicians to develop pathways to ensure that we are maximising that. We do continue to insource supporting both substantive staff, but also using insourcing staff, and we've done that with a good effect in both endoscopy and in our eye care services, particularly around cataract. And we are working with some of the private providers to see what short-term capacity they can provide for us as well, so that we can work through the backlog of services that we have. And I'm happy to take any questions.
Thank you. I believe Jeff's got a question for you.
Yes, I've been involved in the waiting list validation exercise. I think that's been very well done. I was pleased to see that there is clinical involvement where patients has to be taken off the list. That's not the case in the national scheme that Welsh Government are piloting. So I think you're in advance of them there. I believe that the diagnostic centres are going to be key to addressing the backlog in planned care. It would be terrific if we could see that happen sooner rather than later. The other thing I'm wondering about, Jill, is it possible to have planned care hospitals that don't have emergency admissions? I think the 5-year plan is just not achievable if we carry on doing what we were. I recall in the 1990s when waiting times for joint replacement were commonly 5, 6, 7, 8 years. That was the solution, and they whipped through the outstanding cases. It was mainly the non-complex ones. It wasn't an ideal solution, but it got waiting times down to where, instead of complaints about long delays, we have had complaints about people being offered their operations too soon.
Thanks, Jeff. I'm happy to answer that. So in terms of the early solution to that, Jeff, is, as we said, the pulling in the modular wards and theatres, which will be separate from the main hospital, so that we can protect that capacity. We know that we've got the red and the green pathways now, but we also know that in normal winter months, and I think that's what you're alluding to, we get high levels of cancellations because of the unscheduled care. So we have had some really good conversations with our orthopaedic consultants, and we are continuing to have a conversation around Welsh Government about how we develop potential diagnostic treatment centres with elective capacity aligned. What we haven't precisely got to, Jeff, is what does that mean in terms of the size of what that may be. But our orthopaedic consultants have now worked with us and are keen that they have a separation of the elective work where that is feasible. But as you say, Jeff, that we're not going to be able to build that in the very short term. It is longer term, hence the principle of the modular wards and the modular theatres.
Thanks, Jill. I believe Francon Williams would like to ask a question. Francon?
Yeah, thanks, Jackie. Continuing the orthopaedic theme in a way, but it's to do with the elective surgery. I think I picked up from your slides that orthopaedic or restart of elective surgery and orthopedics in particular, orthopedics seem to be lagging other surgeries. And I just wondered whether you could give us an insight as to some of the reasoning behind that, because I'm sure there is, given orthopedics waiting lists and so forth have been a concern, remain a concern for us. Thanks, Jill.
I can, Francon, and part of that is the requirements, the hyperclean requirements that are required for orthopedics. I'm sure, I think Chris is on the call, would support that. So it is one of those where getting infections in orthopedic patients, there are very high risks. It is ultra clean, and clearly we need to manage that risk, and so consequently that's what we have been doing to ensure that those patients are protected, not only in theatre but when they come out of theatre.
If I may, Francon, orthopedics tend to use particular theatres rather than any theatre. So it's not as easy to take that activity and put it into any old theatre. It has to be a particular theatre that's used for the reasons that Jill has outlined.
Yeah, thanks, Joe. It's a laminar airflow theatre that they use, Francon. Ultra clean.
I can't see any more questions on this topic, Jill. Has anybody got anything else for Jill on this? No? Thank you for that presentation, Jill, but I believe you're stuck with the next one. You're doing it instead of ARPON, the one on robotic assisted surgery.
So thanks, Jackie. And can I also, whilst Chris is loading this, and I'm sure I won't do this anywhere near as well as ARPAN, so apologies. you've definitely got the understudy here. But can I just thank Jeff and the teams as well for being involved in that validation exercise, because that's been really helpful for us, and I'm sure for our own board members, Jeff, you've given us a little bit of assurance as well, so thank you. Okay, so if I can move on to the robotic assisted surgery update, and I've touched on this in my previous presentation. So one of the drivers for this, and there's been a long-term desire of North Wales, is to be able to access robotic techniques, and there's a number of different reasons for that. It's a methodology that more and more clinicians are being trained upon. So in terms of recruitment, they're keen to use the skills that they have been trained for. There are improving outcomes in terms of length of stay. So there's a number of different reasons why we would want to do that. And currently, where those services are required for different diagnosis, we are having to see patients travel quite considerable distances, in some cases as far as London, to ensure that those services, that they can access that treatment. And clearly, that we don't believe that that is ideal, and we don't believe that that is right and proper, that people of North Wales should have to travel those distances. So we, as you know, we did initiate a local procurement process via a lease opportunity, initially to support the provision of urology, but the principle would be that we would want to use that across a number of other surgical specialties, particularly around colorectal, gynecology. There are a number of services that could potentially access that in the longer term, but certainly the initial service that we want to use this for is within urology, and I think that's for the purposes, for the reasons outlined. So during the time of the preparation to move forward with our own procurement, and if we had lease, sorry Chris, can move forward, it was clear that in pulling together the lease arrangements, which we would be tied into for a considerable time, there was the aligned with that an all Wales procurement. We have been, and I know Joe and myself have continued to press this button to ensure that we are at the front of that queue in the procurement. So as the robots are allocated, that we are at the front of the queue, and I can assure you that both Joe and I have been assured that this is the case. And as a consequence of that, we are in that procurement phase, and as I articulated earlier, it is planned that that will be with us in the summer. I think we've already I've already alluded to the fact that that would be across a number of specialties. So although we're using it for urology, other organisations are using it for other subspecialties. So there is a real keenness, if you like, to look at a Pan Wales network, so that we're ensuring that we're working on this on an all Wales basis, and there is the shared learning that enables us to move forward at pace. And there is a keenness to develop that robotics physically, as well as the movement into that artificial intelligence, which we're hearing more and more about within these arenas. So moving on, so taking all of that into account, the decision was made to participate in the All Wales tender process. Some of that was financial, because, as I say, we would have been tied into a long-term plan. And this has, whilst it's meant a short delay in the programme being implemented, we're now confident that the day of unveiling, for want of a better term, is very, very close to us. And as I say, I know that Joe is in close contact with the Cardiff and Val CEO, who is the senior responsible officer for this programme, to ensure that meets our needs. So we are the tender process has all been finalised, and we are looking towards how we move forward for not only the commissioning of the new services, but I know in conversation with one of our clinicians, Mark Pollin, described the implementation plan that we need to put behind this. So the procurement process, as I'm sure I don't need to tell any of you, is confidential. It is a very highly competitive environment, and so there are checks and balances that have to be in place before we can share the detail and share any preferred bidder as a consequence of that. And as I say, I'm sure I haven't done that the justice that RPAM would have done, but hopefully I've given you a clear sense of where we are. And I do think sitting alongside this, we need a clear implementation plan to run alongside.
Thanks very much, Jill. As you know, the robotic surgery and the robot was a particular kind of pet of mine and Dr. Christine Evans, who was a CHC member. And we worked a long time in getting stats and talking with the consultants and patients around urology, as it was Christine's field. And we were over the moon when we heard the back end of last year that we would be getting the robot. And we were disappointed when it didn't happen by Christmas as we anticipated. Hopefully we will get the Da Vinci robot, which I believe is the one that the clinicians, especially in urology, were very keen to get. And I just hope that this does have a smooth path now. We can see it in situ in Ysbyty Gwynedd as soon as possible. So
I can't tell you what type of robot that we're going to get, Jackie. I'm no closer to some of that commercial knowledge, but what I do know is clinicians have been involved in that process. So this isn't something that has been excluded clinician. On the contrary, they are at the heart of this. I can also give you assurance, and I'm going to use Jo's name in vain so she can virtually kick me. But both Jo and I, and indeed Sue Hill, are very closely monitoring to ensure that we receive the robot in a timely way, as has been promised.
Well, I think appreciate the presentation, Jill, and thank you. I know you were thrown in the deep end on that. I can't see anybody's hand up, but just as an aside, when that robot is delivered to Ysbyty Gwynedd, I know Jeff and myself will definitely be opening a bottle of something. You will be invited to see it, both of you. And I'm sure it's a bottle of fizzy water you're referring to, Jackie. Of course, of course. Thank you very much for that. But absolutely, we'll ensure that you get you get to see it in all its glory. Thank you very much. Mark, I think that it's up to you now. Perhaps not. Right, we'll go on with the agenda. And I think our next, have we got Ian White with us? Oh, there you are, Mark. Do you want to carry on with this agenda item, please?
Yeah, fine. Sorry, I was caught up with something else. So
it's fine.
Mike, are you there? Or Ian, are you there picking this up?
Hi, Mark, I'm here.
Hi, Ian.
Hi.
So can we hand over to you, please?
Certainly, yep. Thank you very much. So in terms of introductions, my name's Ian Wilkie. I'm the Interim Director for Mental Health and Learning Disabilities. I've been working in the division and the Health Board for the past 6 months. So before I go through the slide that I understand that you can all see, I'm not very good technically, I have to say, and I did confirm before doing this that you were able to all see the slide. Is that correct?
It's
Not
within,
yet, no.
it's within the pack.
Okay, so people can see what I'm talking to. So apologies for my limited IT skills. But before I go through that slide, I'd like to highlight the 4 divisional priorities. So they are, I'm sure we all know them, but I think really important to highlight them because they play a really important part in the work that we're trying to do within the division. So stronger and aligned management and governance, a review of capacity and capability, delivery of safe and effective services in partnership, and engagement with staff, users and stakeholders. And I think these priorities dovetail very nicely with the values of the Health Board, those being putting patients first, working together, valuing and respecting each other, learning and innovation, and to communicate openly and honestly. So I think that the priorities and the values are, for me and Mike Smith being the new Director of Nursing, he's been here for a similar length of time that I have, along with Alberto and Teresa Owen, have been a really useful sort of benchmark for us to utilise going forward. So in terms of the slide, the first bullet point is continued stabilisation of senior leadership across the division. I'm really happy to say, from my perspective, in my opinion, that things are much improved than they were 6 months ago. I'm not trying to take the credit for that. That's been a team effort under the sort of stewardship of Teresa. So the team are happy. We're working well together. We don't always agree, believe me, we don't always agree, but we work well together and we're all very comfortable challenging each other. I'm delighted to say that I'm interviewing for a Director of Operations next week, which is going to free me up significantly in terms of looking at more strategic working as opposed to day-to-day operational matters. And essentially, we're working to the principle of having the right people in the right place, doing the right things, not just within the senior team, but in all the area teams as well. So targeted interventions, if I move on to that. So following the de-escalation from special measures, the Health Board was placed into targeted intervention with improvement required in mental health services. For us, this is a real, I mean, it's not a position that we want to be in. It's a better one than we were obviously before, but it's a really exciting opportunity to move the division out with of the targeted interventions. We've developed a maturity matrix with other colleagues and in close alliance with CAM's colleagues. And importantly, that document just can't be a piece of paper with nice managerial words on it. It needs to be something that's embedded and understood within the division. So to that end, we've already started sharing, although we accept it's not the final document yet, but we've started sharing that document within the division so that people are cited on the roadmap that's going to be utilised in terms of embarking upon this journey. And from my perspective, I think it gets rid of a lot of the vagueness that was around before, and gives people something very specific to lay their hats on, so to speak. And people that I've spoken to out and about in visits to the clinical areas are quite rejuvenated and motivated by the knowledge of such a document. So obviously very early days, but lots of encouraging noises. In terms of divisional planning, the division plans to introduce a number of service developments that will support people to maintain good health, effectively keep people out of hospital, and then when people are in hospital, try and ensure that people are in hospital for the least amount of time as is possible. Moving on to governance, as I mentioned before, it's one of the priorities that I mentioned before. Really important, and thanks to Matt Joyce and Jill for the support and attention that they've provided the division in terms of enhancing and developing what we had previously. So we're now moving from gold command to divisional oversight with all the normal scrutiny arrangements. And certainly, again, in my opinion, I think we're in a much better place now than we were a number of months ago. Partnership working, this was an area that required lots of attention. I think it was something that had slipped quite significantly. A key member of the team, Amanda Lonsdale, has been instrumental in improving partnership working in a number of areas, some of which are listed there. So the Together for the Mental Health Partnership Board has been re-established and is in the process of reviewing its terms of reference and planning a refresh of the Together for Mental Health strategy with partners. And there's a number of other areas whereby we are working much more closely than we were. So again, early days, a lot more work to do, but I think a really positive start. And if I'm being honest, from my perspective, quite difficult to get your head round in terms of all the different stakeholders that are incorporated with the required partnership working. But people have been very patient and very understanding with me, so I'm very grateful for that. CHC Safe Space events. So we've had a number of meetings. We've received the report and recommendations, which we welcome. Not all of it's positive. In fact, quite a lot of it's not positive and certainly not the way that we'd want it. But we welcome the feedback. Provides us with a fantastic opportunity to listen to what's being said, integrate that within our governance and local areas, and look to improve the services that we provide. We've planned, I'm not too sure if we've got dates in the diary yet, for a series of virtual and face-to-face meetings with patients or people that have contributed to the Safe Space events. So again, another piece of work that we're quite excited about. Moving on to ABLET. So we're currently reviewing location options following planning application issues and resident feedback. So that concludes the slide. I'm happy to take any questions.
Thanks, Ian. Before I open it up, I'll ask Lucy if she wants to comment as the independent member lead for mental health. Lucy.
Thanks very much, Mark. Yes, I think Ian's provided a very good summary there. We've certainly seen some significant changes in the division over the last few months. There's a real change in energy across the division, and I've been undertaking a number of site visits myself over the past few weeks, and the commitment of the staff, I think, was very evident in going round, and they're also feeling that improved energy. That said, as you said, Ian, you know, there's obviously, we recognise there's still a lot of work to go, and the feedback that we're getting on patient experience is something that we are absolutely committed to responding to. And the refocusing the Together for Mental Health strategy, making it a proper Together for Mental Health strategy with our partners, I think gives us a really good opportunity as well to make sure that we are going to be able to provide mental health services in the future that are fit for responding to some of the changes that we are anticipating as a result of the pandemic. So I'd just like to recognise Teresa's improved leadership across the division, and also yourself, Ian, with the senior leadership team as well. Thank you.
Thank you, Lucy. That's very kind of you. And if I could just thank you and Mark and Joe for taking the time out to visit the clinical areas. It genuinely very, very well received. So thanks very much for that, and hopefully there'll be a lot more of that in the future.
Ian, it might be remiss of us if we didn't touch upon the tragic suicide the other night and the response to that, please.
Absolutely. Tragic. The staff and patients that work and reside at Hairguest are going through a very difficult time just now. We had a meeting with Jill and Matt Joyce yesterday in terms of a serious incident review. I believe it was the first of its kind that's been used within the health board, and it was a very useful opportunity to touch base and talk in an open, transparent, and honest way about the contributory factors and immediate learning that requires to happen, along with all the other process issues that will happen in due course. But the patient's family and the other patients that reside on the ward and the staff are all being supported in the way that you would expect them to be. But absolutely tragic event, and we're very keen to learn the lessons and get those lessons integrated within all the areas of the division to ensure that there's not another set of such tragic circumstances.
Thanks, Ian. Okay, Francon, you got your hand up.
Yeah, thanks, Mark, and thanks for the presentation, Ian. And yeah, the service is moving forward. I'm pleased about that. Just want to pick up on the partnership points that you made, and in particular, the Together for Mental Health Partnership Board, which has been re-established. I really welcome that, because as you said, the sort of partnerships that you deal with is quite unwieldy to get your head around, and I think that is also some of the patient's experience. You know, that it is quite an unwieldy thing to get your head around, to use your words, Ian. But I wondered whether we fully understand the reasons why that partnership board was disbanded in the first place, and whether those lessons are being built into our forward plans to make sure that that doesn't happen again, given the reliance on partnership working in this area.
A good question. Thank you. I'm sure there'll be other people within this meeting that understand the reasons better than I. But I think from my perspective, I think Lucy's brought an energy that has been assisted by Amanda's creative thinking. And I think it's been really important that we, I think from my perspective, we've been really taking our time to talk about what this board needs to be and what it could be, and that it can't be the health board using it as a sort of talking shop about, telling partners what they're doing, but it needs to be proper engagement. It needs to be working together. It needs to be planning services together for the people that we serve. And my understanding of what happened in the past is perhaps that wasn't always what happened, or things could have been better. But so far, I think it's early days. I think we've taken a big time out in terms of completely refreshing the terms of reference and making sure that people are really happy with them. And we've taken a long time doing that, actually, but I think that's important because that provides the foundation stones for what happens with those meetings in the future.
Yeah, thanks, Ian. And what you've just described there sort of echoes with what Jill told us at the beginning in terms of what she was passionate about, and a leadership approach, which I welcome, which is around that engagement, co-design and co-delivery. And I, firmly believe in this particular service area, as much as any others, that's absolutely essential to the success of getting out of special measures and for what the patients deserve.
Absolutely,
thanks.
I agree. Thank you.
Could I perhaps just clarify, Francon, when you say that the partnership board was disbanded, are you referring to a few months last year when we weren't meeting?
I'm going by the report that's in our pack, which says that it's been re-established, which gives an indication that it stopped.
Right, okay. So
at some point, there's no further detail in the report, but I am aware that the activity stopped.
Okay, so perhaps if I could just explain. So first of all, the partnership board stopped meeting for a number of months last year because of the pandemic. You know, as you're aware, Francon, you know, with, other than a couple of committee meetings and the board, the meetings were stepped down to enable people to respond to the pandemic. When we then were at a point of stepping the partnership board back up again, we took the opportunity for a bit of a reset. So we actually held a workshop rather than a partnership board meeting with a formal agenda, and invited a facilitator to come in so that we could talk about actually how we wanted the partnership board to look in the future. Now, as the outputs then from that workshop were used to inform the review of the terms of reference. So that's what the re-establishment's referring to. It wasn't that it was disbanded, so to speak. It was more about, we took a little bit of time out to decide what we wanted to do, because as Ian's referred to, we were really conscious that what had seemed to have evolved was the partnership board basically being a health board driven meeting, with us telling our partners what we were doing and providing progress updates, which wasn't really the spirit of Together for Mental Health. So that's why we've taken a step back, and we're actually reviewing the terms of reference to include a complete review of the membership of that group as well, to make sure we've got everyone around the table that needs to be around the table. And I've been really encouraged actually by the number of people who have stepped forward to say, actually, can I be involved as well? Because I'd really like to be around the table, which is quite a thing for people to volunteer to be involved in formal meetings on a regular basis. So I found that really encouraging.
I think it's fair to say, Lucy, as well, that we were concerned about the robustness of what sat beneath the strategy, let alone the effectiveness of the group. And I think a key consideration moving forward, and I think we share this view with the executive team, is the alignment of the strategy with the targeted intervention framework, with the additional monies that we are now allocated, and ensuring that those things are in line and capable of securing the improvements that we all want to see.
Yes, absolutely, Mark. And the partnership board also wasn't receiving updates on the delivery against the strategy. So there was no delivery plan coming to it, which we identified as a group that was a real gap. So that's going to be the intention going forward as well, that a delivery plan. It will come through, of course, our own governance process as well for the health board, but the partnership board will receive regular updates on the delivery of the strategy, which will be a full partnership strategy. That's the intention.
Okay, thank you.
Thanks.
So Jeff, you had your hand up next.
Right. My video has been stopped. Yeah, we had great cooperation in the safe space events from the mental health and learning disabilities team, and as Ian said, that wasn't the case before. In fact, it would have been actively resisted. We've been very pleased by the reaction of Ian and the team to the report, and we will be releasing it publicly after the pre-election period. And at that point, Ian, Mike, and key team members have agreed to come along and speak directly to the participants in the safe space events. I think this was really it was really important that the department has widened its engagement considerably by really getting involved with these safe space events. We have agreed that we will extend it to staff as well, and again we're getting great cooperation on that. One of the things I should mention is that for the first time in many years, we met with middle and frontline managers in mental health and learning disabilities, and again, that is a significant step forward. We're also linking with CAMS. In the safe space events, we found that the transition between CAMS and adult psychiatric services was not really as it should be, and was perhaps the cause of ongoing problems in the future. So we feel really that we've been pushing at an open door. There is a great deal of work to be done, and I don't think anybody thinks there isn't. But in terms of the cooperation that we have, the access to patients and staff, it really is very good. Thank you.
That's good to hear, Jeff, and that there is dialogue taking place within the board as well about CAMS that Shaoland, Lucy and Chris are pursuing. So yeah, we are focused on securing the improvements in that area too, particularly the transition. Okay, so I have no further hands shown. So that being the case, we'll move on to vascular services. Jill.
Chris, are you able to share the slides? And as you'll know, I'm not RPAN, so again, I'll do my best to present these slides on his behalf. And some of it, just to put some of this in context, as you know, the centralisation of the vascular, the high-end vascular services took place in April 2019, and the principle that was to be adopted was one of a hub and spoke model. So ensuring that wherever possible and appropriate, there was local access to service, while acknowledging that more complex surgery will be undertaken in Ysbyty Glenclwyd. We had some very valuable insights, courtesy of CHC, so I want to once again thank them, of the feedback of that service and how well that implementation was being received by public, what the perceptions of the service were. And so an internal review was commissioned, and we brought both of the outcomes of the internal review, but also the feedback that Jeff and colleagues shared with us from a safe space events that took place around vascular services. As part of that, it was agreed that an external review would be commissioned. A point in time that was commissioned, and despite COVID, that was able to take place. The terms of reference for that were agreed with the Royal Colleges of Royal College of Surgeons of England, but also the task and finish group, which had been set up following the internal review. And that task and finish group, again, thank you to council members who helped us to pull together those terms of reference and submit them to the Royal College. There are always significant lessons to be learned when we centralise a service. And sorry, Chris, could you click? Thanks. It's really difficult. Unfortunately, I've got some technical difficulties that are not allowing me to do that. There are always significant lessons to be learned by the centralisation of any service, and really recognise the need to give both our public service users, but also the service providers, confidence that we are doing the best that we can in addressing some of the concerns that have been raised. And the contribution that continues with CHC and the input that they're giving us from public insights continues to be really, really welcomed. What I will say is that I'm saying this on behalf of RPAN, but I will say it on behalf of the Health Board actually, that we're determined that that the actions that have been identified and the further actions that are emerging from the Royal College report will be completed and will be addressed to the satisfaction external scrutiny that we would all wish to see. I think it's worth saying at the outset the Royal College review is continuing. They have requested access to notes. We have scanned some notes and sent them across to them, but unfortunately that has not allowed them to do the thorough notes review that they would wish to do. So they have agreed that they will come on site and undertake that notes review, which will help further inform their report. I don't think there are any surprises that from that I'm going to be able to tell the CHC here and now, particularly those people that are on the call that are also part of that task and finish group, that there's an acknowledgement that we need to do more work to strengthen the local sites as opposed to the centralised site, to ensure and absolutely give confidence that you're only going to that central site when you need to, but also that you will be repatriated locally as soon as we are able to do so. Acknowledge that there remains a framework of valuable MDT, but perhaps we need to maximise that more effectively than we are doing, and ensure that we've got an integrated model, not a separated model, that we are maximising our abilities both as the health board, but ensuring that those, I hate the term spoke, but spoke sites are delivering, maximising the delivery of what they can do to ensure that we've got that localisation. As part of the review, they did look at the background documentation regarding the vascular surgery. Sorry, Chris, can you press? Vascular surgery. They interviewed a wide number of members of staff, both in the vascular service, but also those wider in BCU services that may be impacted, including those who are no longer employed by the health board. And as I say, that clinical records review continues to take, is now being arranged now that some of the COVID restrictions around travel were being lifted. The review team considered a number of outcomes and complications as part of that review in the context of national and international standards. So they're able to look at that from a much broader lens than we've been able to do locally from a very objective perspective. They did highlight that the data, given the limited amount that we currently have, should be treated with caution. Nonetheless, they recognise that it is data that we should be using regularly to help inform our practice and our service. So what recognise that we need to do that on an ongoing basis, but that the data that we have currently is work in progress. They found it difficult, therefore, to draw some conclusions. Sorry, Chris, we go on. Particularly regarding aneurysms, because of the limited number of cases and the statistical variance that will undoubtedly ensue as a consequence. And for example, one of the consultant vascular surgeons included only data for aneurysms for a consultant vascular surgeon who's retired. So we really, they are cautious with that data. What I am going to do, because I know I'm not going to do justice to some of the statistics that are there, and I know, Jeff, I've agreed that when ARPAN is back, yourself and I and whoever you want in the room can go through these in more detail. And I know that they will be shared with the task and finish group. So I'm going to try and go through some of the data very quickly, so that we're being transparent around the data, but focus on what the recommendations were, if I may, Chris. So you'll see on slide 8 that there are a number of statistics outlined there, looking at the national rate versus the BCU rate, and you'll see that in the in-hospital mortality amputation does seem to be, we seem to be a significant outlier. However, that has been reviewed by the internal clinical governance process, action plan and notes process of the Royal College of Surgeons for external and independent scrutiny. So they've looked at that, they're looking at the actions, and they are sharing that transparently with the team. There were 9 recommendations, some of which have been concluded as part of the task and finish group work. We'll be listing those as we go forward, and there are 2 broad headings for improvement. That improvement plan is being overseen by the acting executive medical director. It will be overseen too by the committees, including quality safety executive, where we have CHC representation, and so we'll have the CHC representation both in the task and finish group, but also in the oversight. It as is at the moment being operationally supported by the acute site director of YGC. We are in a place where the current vascular network manager has secured a position, a promotion elsewhere, so consequently we will be recruiting to that post to drive some of these improvements forward. So if we go on to what we are looking for the areas of improvement, I don't think for those members of the vascular task and finish group there will be any surprises here. So the agreed pathways for timely and effective treatment of the spoke sites I've alluded to. So the pathway is scheduled to hit the clinical advisory group has actually gone through the clinical advisory group. I think then it's about the implementation plan and audit of adherence to that clinical pathway, so that we can get confidence not only that it has been signed off, but it is being utilised. We are looking at bed capacity across the whole of the health board, and included within this is the vascular bed capacity, and ensuring that we have adequate timely transfer to local sites, and we are maximise the expertise that is on that sites. So we are looking at the alignment of the beds in that bigger piece of work. It has been more complicated because of the pandemic, because we have lost capacity across the whole of the health board, as you're well aware, during the pandemic, as we've moved towards more social distancing, different ways of working, and indeed the red and the green pathways. One of the other things they outlined was effective use of the hybrid theatre. So we maximise the use of the hybrid theatre for those cases which are most appropriate to it, rather than putting every vascular case through there. That piece of work is being now led by our theatre team, and with the clinical input from our consultants. Finalisation of a number of pathways, including the major arterial vascular surgery. Again, that has been agreed. Since the report was pulled together, we are now in the implementation phase, and I would reiterate, we just need to ensure that that is thoroughly audited and those audit results presented, so that we are confident that the implementation phase is being embedded, but equally that we are monitoring the effectiveness of that in case it needs to be adjusted. The development of the non-arterial diabetic foot pathway, that process has commenced. It is being led by one of our senior diabetologists at the moment, and that is progressing. It's got input from podiatry colleagues, so therapy colleagues as well, And I think it really is important that is driven from that context rather than the vascular team. So absolutely, they are involved. We've got orthopaedic surgeons involved, so it's very much a multidisciplinary pathway. So there has been work undertaken. I've also been given the name of the lead for the diabetic foot pathway across Wales. So when Alpan is back, we will be connecting in with that individual as well to give us offer us some support. So as I said, there are other pathways that are currently in draft that they are wishing to see moving at some pace. We have confirmed who the leads of those should be, and they are beginning to move forward. I think a key one is improving the process of clinical governance to ensure that we are reporting upwards and have clear sight, line of vision between the service and the board, and that to ensure that we are getting confidence and assurance that all of these pieces of the pathway, pieces of the jigsaw are being put in place. As a consequence of that, one of the conversations Arpan and I have been having is a reconstitution of that task and finish group that better reflects the recommendations that are emerging from the Royal College report. Absolutely keeping our CHC representation, but we may want to, and I think we do want to, reflect the membership so that the leads for each of these actions sit within that group and can give us the assurance or otherwise articulate what support they might need around that table. So in terms of the recommendations, I think recommendation improvement will come under two broad headings, about improvement of communication, but equally clarifying the centralisation plans. And I think that comes back to the conversations we've had around the spoke sites and how we use those spoke sites. I've talked a bit about the diabetic foot pathway already, and as I say, sorry, Chris, that is moving forward now at some pace, and we do have input from, as I say, we now have orthopaedic input that has been kick-started in the East, and we're now working to develop that across the whole of the North Wales, so we've got a consistent approach. So the Royal College Review report will be, sorry Chris, will be reported in line with our governance structures. So it will be going through our Quality, Safety and Experience Committee, and it will be going through our public board meeting. As I say, it will be further informed by the notes review that has been that is taking place as we speak, as we're now giving them access locally to the notes. So it will be further informed, I am sure, once the Royal College representatives have had a sight of those notes. I'm happy and will do my best to answer any questions.
Thanks, Joanna. Thanks for picking that up. So I've got a number of people wanting to ask questions. We'll start with Adrian Drake Lee, then, please.
Yes, it's the first is one of principle. Thank you for that presentation. I think one of the problems that I have found is how well data were recorded, both previously and more recently, about the activity. So if there is a national audit, I think, and there are about 30 of these in the United Kingdom, we would expect the health board to be committed to getting the doctors and those involved in care to submit their data to all the national audits. So it gives the patients reassurance of the practice. And you highlighted the problem with the National Vascular Registry, which I think really is a problem of submitting data rather than accuracy. The The next thing I would like to see is that the Health Board does publicise what the Royal College of Surgeons has said, even if it is only temporarily, to set patients' mind at rest that the service is running well, and explain the issues around why the notes have taken so long to be examined. So I'd like to see that. When it comes to pathways, I have been concerned that the Health Board hasn't been able to sort out something as simple as groin abscesses aspergillus. It's still ongoing, and it's only a few patients, and it should have been sorted out by the Health Board now. And I agree that the lower limb service is vital to being developed properly, because if you've got a good service in the community, it prevents people coming into hospital. So I think it's actually providing the community service. And I think that's one of the key things that the Health Board does need to develop to prevent patients coming there. So that's really the 3 or 4 points I wish to get across from my involvement, both with this and the previous task and finish group.
I'll answer it as best I can. Adrian, I'm more than happy to have you in the conversation with ARPAN. In terms of the data submission, completely agree with you. I think that is something that as a Health Board, we've got to ensure that all of our national audits are contributed to. And we have set up an effectiveness group, which ARPAN is now chairing, to ensure that we've got those across a number of different subspecialties, including this one. In terms of the publication of the report and upward, that reports into, moving forward, that reports into our quality safety experience group, to ensure that the board has sight where we do not have perhaps the contributions that we would expect, so where there is an exception. And that is part of the governance work that we've been doing much across all of the Health Board, and is part of our targeted intervention framework. In terms of the publication, I think I outlined on the slide, there is no willingness to hold back on this report, and it is going through our governance processes. We're in a difficult scenario. I don't profess to be an expert on this in terms of PERDA, but it will be going to our board. And in terms of some, that's where I think I said, Adrian, at the beginning, for those people who sit on the task and finish group, I don't think there are any surprises here, and I think there are areas that we need to get some pace behind for the benefit of our public and our patients. We can avoid this in certain circumstances, and we should be doing all we can to get the referrals into a vascular, so that the ones that really do need to come into our vascular services can be dealt with in a timely way. So take each one of your observations, and I know you're as part of that group, and I very much hope that you're willing to continue in the role that you have as we reconfigure it, and we'll be working alongside you with that.
I think it's important to say that the board was not content with the handling of the initial review and not assured, which is why we agreed with the executive team that there should be an independent review commissioned. The second thing is that we are, as Jill has already said, expecting it to come to the May board, along with the associated action plan, which is clear about what is going to be done to respond to not only the independent review, but the prior review. And we are disappointed that some of the pathways have not been in place before now. And I'm sure we're at one with ARPAN and Jill and Joe to ensure that we do not find ourselves in this position again moving forward with other service reconfigurations, which are bound to come at some point following engagement and consultation with the CHC and others, because there are clearly lessons to be learned, and those lessons must be learned. Richard, I believe you're next in terms of wanting to ask a question.
Yes, Mark, and to Jill. I'm disappointed, to be honest. We, as Adrian said, we are slow with the diabetic foot pathway. Figures wise, I have concerns because since service change, we've been removing 2 legs a week within that ward. We've chopped off 155 legs since up to the end from April 2019 until the end of 2020. We chopped off 155 legs, and it's the suffering pain from the patients. We've got to look at this. It's unacceptable.
So,
and I don't want to say too much. It's just, I find it, and being a vascular patient myself, I feel worried going into Ward 3 because I have to ask questions, I have to propose, talk to the surgeons, but the figures speak for themselves. It's really worrying. And I've also been informed that it was 4 deaths from open AAAs during this year as well. I'm worried about the service, Mark and Jill. It has to improve.
So Mark, if I begin, I'm sure you or Joe may want to come in. First and foremost, Richard, I think as Mark alluded to, the board shared those concerns that you've raised and are very, very keen to see significant progress within the vascular service, but also transparent progress within the vascular service. And I think that I think the points you made, if you are nervous about accessing our service, then others will be nervous about accessing our service. That is not a good place to be from anyone's perspective. So I completely hear what you're saying. I will reiterate Mark's comments, I'm sure he will do so himself, that this is a topic that the board are looking for progress at pace, but actually significant board scrutiny. I would suggest that includes, as I say, the task and finish group and taking on board your own and Richard, Adrian's points.
If I may as well, Richard, just to acknowledge you made the point about pain and suffering, which I absolutely do acknowledge. I have spent some time with the vascular surgeons and the multidisciplinary team, and they are committed to excellence in care, as are the clinicians who are actively working now on the diabetic on the foot clinic pathway, with a commitment to make progress in such a way that we are able to reduce the number of lower limbs that have to be amputated by looking at the whole patient pathway from primary care into secondary care and specialist services. So I hear your pain. That's not a trite comment, I acknowledge. But I have met with the clinicians and spoken to them myself. I see for myself the commitment to get the service right across each of the acute sites, and of course into primary and community services, all of which play a very important role in terms of managing vascular challenges associated with people's feet. Thank you.
Thank you.
Okay, I don't propose to say any more. I think I've made the board's position clear, and as Jill has alluded to, the board will be keen to monitor and see progress and to learn the lessons in terms of this service change, because there are significant lessons to be learned. Jeff and then Franklin.
I support everything that Richard has said. Richard, of course, has direct and personal experience of this service, and it's really important that he and other service users listen to. I think that openness and frankness is the way forward on this. I'm pleased to hear that, that there'll be significant disclosure in the May Health Board meeting. I think that's really important. And at some point, the CHC will speak to patients again when we had hoped that the improvements would have been made by now, and we could speak to patients and hear their feelings about it. But given that the progress we wanted, that we all wanted, hasn't been made, I think that will be delayed now. Thank you.
Thanks, Jeff. Franco.
Thanks, Mark. I just wanted to make an observation around the data, the table that was presented in slide 8. As I understand it, that table compares the national vascular data over the last 3 years. And the observation I just want to make is around the stroke data, which is the last entry in the table. The BCU rate is 4.4%. The national rate is 1.9%. So that indicates the Betsy rate is higher than the national. But it would appear from the descriptor in the row that the data is not the last 3 years data, it's the previous 3 years data. So I wondered what the position was, I guess, but taking the data on face value, my observation was that there was no comment relating to that performance in the recommendations.
So Francon, I am happy to take that conversation outside and be transparent with CHC, and just conscious RPAM might be better able to articulate that because he's much closer to this.
Yeah,
but it's certainly something in terms of the stroke pathway. I think we alluded to it earlier. It is something that we are committed to as a health board in terms of taking that forward. I think it was raised earlier in this meeting.
Yeah, there was some concerns from Joe Rameser, wasn't there, about strokes? So
there was, and that is one of the services we're reviewing.
And just to be transparent, I raise it because the stakeholder reference group who I represent have had a lot of interest in strokes, and particularly around the performance. Thank you.
And at the last Finance Performance Committee meeting that I chaired, the business case on stroke of some significance was agreed.
Great.
Okay, Adrian, did you want to come back in?
Yes, thank you very much. Basically, I don't think we could have much faith in the data submitted to the MVR. I think about a third of the operations, from what I can see looking at it, and we've both, Richard and I, have been lobbying to get the OPCS 4 codes produced by the hospital to actually show what the activity is. And I think we've got a meeting happening on the 30th of this month to look at the figures. That's, as I understand it, what we're going to do. So we should have a clearer picture of what the actual activity is. And that's one of the problems which I think is widespread, is how well data were entered in and recorded. And it goes on to consultant appraisal, because if you haven't got faith in how well the data is recorded, it's how well can you appraise your staff?
Okay, so we'll look forward to the outcome of that meeting then, Adrian, and thanks to you and for Richard for pursuing it. I think the other problem we face, of course, is how the data was recorded before the reconfiguration occurred.
That has been one of the challenges, Mark, but I think the point made about transparently publishing our data moving forward and ensuring we are submitting data to the relevant national audits will ensure that we've got transparency in the future and consistency.
Yeah, which is why I think you've really got to say what the College of Surgeons report says now in some form of public statement, allowing for the fact that it is incomplete, so that the public know that the process is open. You know, I think you've got to be active about it rather than anything else. And
that truly is the plan, Adrian. We are just a tad concerned and sensitive to the fact we are in PERDA, and there are certain constraints placed upon us and other health boards in terms of what we can and can't publish at this time. Joe, did you want to come in? I saw you flash up on the screen.
Oh, only to say what you've just said, Mark. Thank you.
Okay, thanks. Jeff?
Yeah, I think you're absolutely right about the PERDA issue. We've held back on publishing our mental health safe space report because we don't want it to be hijacked during the election period. These things are far too important to do that. And I completely agree with Adrian that as soon as possible, and practically that's post-election, there needs to be as much disclosure as possible, preferably full disclosure. Thank you, Mark.
Thanks, Jeff, and that is our intention. I can tell you that now, as Jill has already highlighted. Okay, so there are no further hands raised. That was a really helpful, important conversation. But we'll now move on to the 111 implementation. And Chris?
Thank you. I'll just share my screen again. Bear with me. I'm going to go slow. There we go. Okay, thank you. So, yes, 111. So, as a very quick overview, although I suspect most people are well familiar with 111, it's a simple, easy to remember free phone number, which is used widely across the NHS, across the whole of the UK now. It provides single number access for urgent health information and advice, as well as signposting. So urgent health advice as opposed to emergency health advice, which is 999, or routine, I need to rebook my diabetes appointment, or that type of access, which would generally be through the individual GP provider. The way that 111 operates is it brings together call handling for various parts of that urgent healthcare system. Predominantly that's the GP out of hours service, but also NHS Direct, which in Wales, in the form of NHS Direct Wales, has provided a service to individuals who want to contact them rather than out of hours as well. And the intention is to bring that together into a single service. Across Wales, 111 is well tested now. In fact, we are the 6th health board of 7 to be implementing 111. So there's a lot of work in South Wales that has been undertaken, and a lot of learning as a consequence of that to share with us in what is a partnership between a national programme which administers 111 and the health board, which currently provides the GP out of hours service. And the reason that we are sharing this in part today is because of a need to bring the timescale forward, and that's for technical reasons. partly due to the procurement of a new IT system on an all Wales basis, which will be difficult to implement if we are not within that larger family. And also because of some telephone technical issues and issues from a NHS Direct Wales perspective. It's probably also fair to say that during the pandemic, there have been some challenges in terms of getting urgent coronavirus guidance out to individuals, because not all health boards have been able to access 111, and certainly some of the national comms early on advised individuals to contact 111, not quite recognising that not everybody in Wales could do that, and so consequently the system was very rapidly rolled out to allow 111 to be used in all of Wales for coronavirus. And to some degree that's been successful, but to some degree it's also caused a little bit of additional confusion. So for all of the above reasons, and the plan which as a health board we've agreed to, is that we roll out 111 to be available in North Wales from the end of June of this year. Because of that, there's a lot of work being undertaken. The Welsh Ambulance Service Trust will predominantly employ call handling staff, as they do in other parts of Wales, to man those early points of contact with the 111 service. And they have a recruitment campaign underway at the moment. And particularly mindful of the need to ensure that they have sufficient Welsh speakers employed who are able to work from a North Wales base and are familiar with those subtleties, and I think at times more than subtle differences between North Wales Welsh and some Welsh dialects elsewhere in Wales. So they are making good progress in terms of employing both Welsh language speakers, North Wales, and additional call handlers and nurse triage staff. There are a number of benefits that we would expect to see. First on my list, I've got the consistency across Wales as well as across the UK. Makes it much easier to communicate to the public in terms of national campaigns when 111 means the same wherever you are and is accessible wherever you are. So in that respect, that will be advantageous. I referred to the fact that we currently have NHS Direct Wales and GP out of hours, and I'm very well aware from a professional perspective of the frustration that some of the handoffs cause, either for people phoning NHS Wales Direct and working through a triage process with them, just to be then told they really ought to phone GP out of hours and have to go through the process from afresh, or vice versa, when they're triaged in GP out of hours and are then advised actually probably there are better ways of dealing with that and transferred over to the ambulance service or to NHS Direct. So we would expect to reduce all of that because there will be a single pathway. It offers much greater resilience for us at the moment in South Wales, whereas they had separate call handling services previously. They now still continue to run their call handling on a geographical basis, but where there's particular excess volume in one area compared to another, they are able to allow call handling to move across sites. In the same way as when you phone 999, your phone call will often usually be picked up in North Wales, but may sometimes be picked up by an ambulance centre somewhere else in Wales. Alongside that, NHS Direct is undertaking work on their existing online presence, so that as part of 111, there is a greater web offering for those individuals that choose to access services in that way. Not least in terms of patient benefits, having standardised and evidence-based pathways across Wales is hugely advantageous. If we go back to a pre-111 environment, the GP out of hours services across Wales used to try to standardise their pathways as far as possible, because it helps enormously when it comes to audit and benchmarking. Us being part of the 111 family will again help us to benchmark and audit our activity against those established 111 pathways. It offers us some additional benefits from a service and workforce perspective. We, in many respects, are at a leading edge in terms of how we use a multidisciplinary workforce in North Wales for GP out of hours. But in other areas, there are still things for us to learn from, and opportunities for us to see how different members of teams have been able to deal with various different clinical scenarios. And having that standardised set of pathways will also help us to make the best use of that highly skilled, highly capable, but sometimes difficult to deploy multidisciplinary team because of the volume that you require. I've touched upon the efficiency of pathways, getting to the right person, the right time, the right way, the right place, all very important. And all much easier when we're working as one family, providing equivalence of service. 111 has within it some much more sophisticated algorithms in terms of being able to work through workflows, monitor how the system pressures are, and make adjustments in a proactive way than we're able to do as a single organisation, and that I would expect will allow us to bring in some benefit from a workforce and service efficiency perspective. And then, as I've already touched upon, there is this current frustration of phoning one service and not only then being passed over to another service, but actually having to start the whole story from the beginning because the record currently does not transfer. Not only here will we have a single pathway, but we'll have a single patient record through which to transfer at the same time as that conversation moves along. So from a communications point of view, June will be very quickly upon us. There is a comms plan being prepared. I've put here by the 111 team. What I actually mean is the BCUHB 111 team in partnership with the national 111 team. Our comms team have done an awful lot of work on this, and it captures the learning from rolling out 111 in 5 of the South Wales health wards. On a communication matter, it is important to stress that whilst 111 will come in June, we won't just be immediately switching off the old numbers and the old methods of access. They will run in parallel. So even if you have the old out of hours number programmed into your phone or NHS Direct Wales, then you will still get through into the new service without having to redial. I'll stop there. I will pick up any questions if you have any, but I think this is good news and good progress for us in North Wales in terms of particularly our out of hours offering.
Okay, thanks, Chris. Are there any questions? I can't see any hands raised, but this is the last chance to do so. No? Okay, so Thanks, Chris. So we'll conclude that item there. Before we go our separate ways, Joe, do you want to update on where we are with the incident at Wrexham Milo, so we're all aware?
Thank you, Mark. Just to say that following the advice of our partners, North Wales Police, we have stood down the major incident. A number of suspect packages were found, but that's all they were. And we will start recommencing services in a planned and organised way. We have we're looking to communicate to acknowledge the support of our partners, and to thank our ambulance colleagues and our patients and staff for their patience. Pleased to report the incident and ended satisfactorily. Thank you.
Thanks, Joe. So, Jackie, before I conclude the meeting with your good self, is there anything you wanted to say before we conclude?
Yes, but it's to Francon Williams. I've worked with Francon for 6 years off and on the stakeholder reference group. He's been very energetic, driven, and has put the stakeholder reference group, I think, on the map with his hard work and diligence, and he will be missed in that as chair of that organisation. So it's just to say thank you to Francon. And also, while I'm thanking, is to thank the people that have taken time out today in difficult circumstances to give such a detailed presentation. So thank you.
You took the words out of my mouth in terms of Francon, Jackie. Thanks for doing and saying that. Francon, I have a chance to say thanks to you again, no doubt, but let me echo on behalf of your colleagues our thanks, and particularly my thanks for all that you've done. The chair of the forum, as you say, Jackie, and his chairing ability has been wonderful, and also the quality of the questions he posed today is just typical of Francon. So, Jochen Francon, and we wish you well in the future.
Thank you for your kind words, both of you.
Okay, so Jill, have you got your hand up? No, you're not. You just got thumbs up. Okay, so we'll conclude it there. So thanks very much for everybody who participated in the meeting. We will look to do what we've committed to do, of course, today in terms of the actions we've agreed. And we look forward to meeting again in due course. So, Jochen, who will enjoy the rest of your day.
Thank you. Bye-bye.